Good morning and welcome to another session of ASM Live at ICAC, this year in Chicago. The ICAC meeting is the Infectious Diseases Annual Meeting sponsored by the American Society for Microbiology. In this session, we'll be talking about Clostridium difficile, emerging issues and treatments. Before we introduce the members of the panel, I want to introduce myself. I'm Jeffrey Fox of Microbe, the monthly magazine of ASM. And for those of you watching over the internet, we encourage you to ask questions. Use hashtag ICAC. For those of you in the room, we urge you to ask questions later on. Before you do so, raise your hand. Someone will bring you a microphone, then introduce or give us your name and who you work with, and ask your question. So now to the panel. We have three people from the session, and to my immediate left is Clifford McDonald of the Centers for Disease Control and Prevention in Atlanta. Sitting across at the second table to Clifford's left is Erik Dubberke of Washington University School of Medicine in St. Louis. And at the far end is Glenn Songer of Iowa State University in Ames, Iowa. I think we'll go in that order. And Clifford, if you would give us a 2, 3, 4 minute summary of the highlights of your presentation, and then we'll go through the panel and then have a discussion and follow up.
Well, my presentation will be focusing on new vaccines that are under development for Clostridium difficile. At the Centers for Disease Control and Prevention, we are taking this problem of Clostridium difficile very, very seriously. It's a major healthcare-associated infection. Although we don't have precise burden estimates, we think that there may be as many as 500,000 cases annually in the United States. Not all of those are healthcare associated, however, but the majority are. And in the area of healthcare associated infections, we are working in the areas of surveillance and prevention. A hope is that there will be a vaccine at least within this decade. Approved. It's still, all the candidates are still at the fairly early phases of development, but there is great promise. This organism causes disease, of course, after people have been exposed to antibiotics that alters their lower intestinal flora and opens up the opportunity for the organism to get a foothold and produce toxins and cause the disease, colitis. And sometimes death. An important defense mechanism then, of course, is an intact intestinal flora of the lower intestine bacterial flora. But another important defense mechanism is an intact immune system. And it's clear that there's an immune process going on, immunity that is breached, especially in older individuals. So vaccine is hoped to boost that, elevating levels of antibodies to the toxins. So that's a promising area of research and development right now, and I'll be discussing that.
Okay.
Yep. So in my presentation, I'll be talking about C. difficile onset in the community. Although C. difficile infection is primarily associated with people who have recently been people who are hospitalized or recently hospitalized, or in some sort of healthcare institutions such as nursing homes, C. difficile infection does occur in the community as well. Many of these people have recently been discharged from a hospital or a nursing home, and again, people that were just discharged in general tend to be sicker and more likely to have been on antibiotics than people otherwise out in the community who haven't been hospitalized. So they're probably at an elevated risk even after discharge from the hospital for developing symptomatic infection. And it's also important to note that C. difficile in the community may also contribute to C. difficile in the healthcare setting as well. Some of the studies I'll be presenting have examined the molecular epidemiology of C. difficile, looking at the specific strains of C. difficile that occur in the community compared to in the hospital setting, and there's a significant overlap between the two. And also some studies looking at the hospital setting find that there's new strains always introduced. So presumably it's coming from someone coming into the hospital with C. difficile. And so there's probably a back and forth between C. difficile infection in the community as well as in the hospital setting.
Okay, Glenn, if you would give us a brief summary.
Sure. As you might guess from my origins at Iowa State, I work with Clostridium difficile infections in domestic animals, primarily food animals. Although, excuse me, drawing a barrier between what goes on in humans and what goes on in domestic animals is really not possible. There's overlap at that barrier. I'm basically a problem solver. I work on Clostridium difficile because it's a problem for producers of various domestic animals. In the late 1990s, there had been one report in Canada of Clostridium difficile as a disease agent in baby pigs. However, it was thought of as a curiosity and anachronism. And it was along about then that in the process of studying Clostridium perfringens type A as a cause of enteritis in baby pigs, that my group and I discovered difficile as a major cause of infection in neonatal pigs. And in fact, it is the most common uncontrolled cause of enteritis in pigs 1 to 7 days of age. Since then, we have documented it as a common pathogen in neonatal calves. Of course, from a couple of decades ago, it was known as a cause of serious, often fatal disease in neonatal foals. It has since come to be recognized as a cause of antibiotic-associated diarrhea in horses. So working on the domestic animal side has its rewards and its challenges, as you might imagine. Domestic animals have a more rather relaxed view of sanitation than most human beings, at least. So those things come into play. And then there's the accompanying bit of information that some strains of the organism that cause disease in domestic animals are of apparently increasing importance in humans. And so people, my group and others, have looked at the possibility of a route of transmission from the animals to foods to humans. And worldwide now, there have been studies looking for difficile in retail meats and other foodstuffs, including salads and things of that sort. And it can be quite common, actually. And the specific ribotype that is important in causing disease in both the domestic animals and in humans also occurs in these foods. So we've not yet proven a flow from the domestic animals to foods to humans, but we're still evaluating that as a possibility.
All right, so the epidemiology is still out in terms of plotting a path from the farm to healthcare settings or community incidents of C. difficile infections in humans. This is speculation at this point. It's plausible, but there's no proven incident.
Now, the evidence gets better all the time, but it is definitely not a proven method of transmission at this point.
Okay, I see already questions from the audience, so I think we should honor that, and I'll get to my questions later. Jim, there's somebody over here, and both sides of the room, left and right. Yeah, raise your hand again, please.
Question for Glenn. Sorry, Annie Jones, Bugs and Drugs. In terms of domestic animals, do you think the pathway is from consumption of products, or do you think it is farm animal or farm worker transmission?
It could be either or both, but it seems reasonable to hypothesize that if spores of Clostridium difficile are present in retail products, and if those products are not subjected to pressure cooking before consumption, it just makes sense that people are at least exposed. Now, you know that once they're exposed and colonized, there's still planets that need to align in order for disease to occur. So we may be a long time proving that such and such a food leads to colonization and eventually to disease in people.
I mean, I don't know about in the United States, but certainly in terms of food production in Europe, for example, potatoes. I know you mentioned salads, which obviously people don't cook. But when potatoes are harvested, because supermarkets like nice, clean, not dirty potatoes, they go through potato washers, which are not cleaned particularly, and the water tends to be recycled. So, as I say, that was part of the reason for the question.
Before we shift from this subject or this set of questions, let me follow up a bit. Surely there are molecular markers that would enable a researcher or an epidemiologist, somebody of that stripe, to determine whether the strains that are found in human patients are the same as those in animals, and you could have at least more evidence that what you're talking about is happening or not, that you wouldn't, I mean, is somebody following up on that sort of analysis?
Yes, somebody, namely me. I have some money from
good.
the U.S. Department of Agriculture to do a study looking at those issues. So maybe we'll know.
But no results yet?
No results yet.
Okay, good. All right, we have another question.
Hi, Laura Pullen, Clinical Podcast News. Dr. McDonald, so you talk about the elderly and you talk about people that are in and out of hospitals and chronically ill. Are you following C. diff infections in children? Because there's some research coming out of England and Canada and California suggesting that the increased incidence of C. diff in the population may be associated with autism, especially late onset autism. And a lot of parents are sort of intrigued by the concept of the propionic acid being produced and acting on the brain and affecting behavior. Are you all following that at the CDC, or what's your opinion about that research?
Well, first, in terms of children, yes, in fact, we've published on using available data sources a demonstrated increase in hospital discharges among children that has paralleled, not in terms of rates, actual absolute rates, but in terms of trajectory, it paralleled the increase in adults over the last 10 years. So, especially in children over 2 years of age, there does appear to be an increase in C. difficile risk in hospitalized children, especially those who are debilitated from cancer treatment and whatnot. Also in our emerging infections program, this is a national representative sample of population, over 10 million population under surveillance. we're really looking forward to the next year. We'll see some early results from that where we'll see some of the best epidemiologic data. And that'll include data from children down to 1 year of age. So we'll have that in terms of incidence of disease. That'll be just surveying for incidence of disease and describing the epidemiology in more detail. I think what you're talking about is some work that I know I've read some articles from Sid Feingold in the past, and about, it was not just Clostridium difficile, but also just the altered, I think this has been described for a while in autism, an altered GI symptomatology, and I think his work has actually described some differences in the microbial flora, or the, not the microbiome, the microbiota of the intestines. That's certainly an interesting area of research. I think that's where it's at right now in terms of a public health problem. I don't think it's been described to that level where we're yet ready to conduct some surveillance. I think the whole area of the microbiome, the human microbiome, is very interesting. I predict that next year at ICCAC we're going to see a lot more on that. I actually searched the schedule, didn't see much on it in this particular meeting, but I think we'll be seeing more and more. The Human Microbiome Project, as you know, is funded by NIH. It has not probably been as hypothesis-driven as it needs to become, but I think that these are some of the hypotheses to look into. It's interesting, the lower intestinal microbiome seems to become established pretty much in the first year of life. And in contrast to the issue you brought up, I think there's a little better evidence for things like atopy or allergic disease, asthma, and those things coming up later in life when there's been some early or slow development of the intestinal microbiome. So I think we're still looking at that as CDC, is what is the public health role in that, in a lot of that work. It's still very early. I don't think we have any really proven associations, but certainly we'd like to work more and more with NIH in trying to pose some of those questions.
I'd be curious, some parents, so you know there's many non-mainstream treatments for autism, and some parents are looking to vancomycin as a treatment for autism based upon this sort of, maybe interesting hypothesis. How do you feel about that?
Well, again, I can't, I'm not an expert on autism, understand that, and there's a lot of different work. Last I've looked into that, there's of course a lot of different work, a lot of genetic markers being looked at. I think that from my understanding, it's too early from a public health standpoint to recommend that, and certainly we know there are problems with antibiotics. Vancomycin, like every other antibiotic, perturbs this microbial flora, the microbiota, and so it also even leaves people at increased risk for symptomatic Clostridium difficile disease after they get off the vancomycin. So that in itself would be reason to pause.
Yeah, actually, I'd like to add a comment there is, C. difficile was first described in a study where some investigators in 1935 were studying the establishment of intestinal flora of neonates, and 50% were colonized with this bacteria, subsequently over time named Clostridium difficile, and that 50% colonization in newborns and children less than 1, children less than 2 has been consistent over time. So the increase in infection we're seeing may be a different phenomenon, but as far as the presence of C. difficile, we know it's very common in childhood and appears to have been constant, since 1935 when the organism was first described.
Another question in the room, please.
Dan Keller, Medscape. 2 questions. One, just a clarification of a term you used. You said ribotype. Is this typing by ribosome structure or something? And would that have an effect on antibiotic spectrum sensitivity? And the second one is, can you elaborate, Dr. McDonald, on what kind of vaccines you're producing? Are these injectable or oral, and do you get a gut immunity, and what are you aiming for, and how?
Ribotyping is in this case, is a PCR-based test. We look at these PCR, the appropriate region out of the genome, and then separate those fragments in an agarose gel and look at the pattern, how many, what sizes, and so on. And that becomes characteristic. There are now about 200 ribotypes of difficile.
So it doesn't pertain to ribosomes?
No.
In terms of vaccines, CDC is not, of course, producing vaccines. We are working with industry. Industry is really in the lead, obviously. We are trying to, where we can, provide epidemiologic support to the field in general to help understand. That presents its own challenges. The vaccines that are farthest along is the Sanofi vaccine I'll be talking about. It's a whole toxoid vaccine, actually a formaldehyde denaturization of the toxoid to cause it to lose its enzymatic activity, but it's still immunogenic. So antibodies to toxins A and B have now been shown quite well to be protective. And actually the most recent evidence of that is in the form of a monoclonal antibody that now Merck has licensed, which was demonstrated to actually prevent recurrent disease in a clinical trial. So the concept of actually giving someone toxoid specific or toxin A and B specific antibodies and preventing disease has already been shown in that monoclonal study, that albeit recurrent disease. And actually there's been some proof of concept of primary prevention through a vaccine as well.
Like with diphtheria or something, it would be an injectable vaccine?
Yes, it'd be injectable. Yeah, that's right. You also asked about mucosal, and it does appear that injectable vaccines will work for this, and whether that leads to some secretion of IgA in the gut also, it may well do that. There are other vaccines under development that are ingested though too. They're very early, and I'll touch on those.
I might add there that on the domestic animal side, where a huge amount of vaccination work has been done on Clostridia of many species, it's generally agreed that the important response is a circulating antibody response which meets up with the toxins at the mucosal surface when the infection process starts. So if difficile behaves the same way, then humoral antibody is likely to be the most important component of the immune response.
Like salt versus saline, which way you get it?
Sure.
Let me pursue a couple of issues that have come up. One is I wondered whether we were talking about C. difficile in children, the possibility of it. Is there a comparable syndrome as to what happens in the neonate pigs in the human population? We don't seem to hear about C. difficile related diarrhea in newborn children, as far as I know. Or are we missing something there, or are they colonized more or less normally by C. difficile and it's a non-pathogen if the child is healthy otherwise?
Yeah, so since I kind of brought that up, I'll
Yeah.
comment on that. So it does appear, we don't know if there's a specific age threshold. We don't know the exact reason why, but C. difficile does not appear to be able to cause infection, or if it is, it's very difficult for it to be able to cause infection in newborn humans. It's hypothesized that newborn human colons don't express the receptors necessary for the toxins to act, but we still the actual toxin receptors have not been fully characterized, so it's been unable to actually study that.
So it's a very different pattern of disease compared to domesticated animals, to food animals, right?
It's also species variable. I mean,
Yeah.
The neonatal pig, some of Glenn's work has shown, I think you showed some actual binding or at least attachment of IgA, biotinylate toxin A, to enterocytes in the neonatal pig. And Erik's describing some work in a rabbit model where they showed that it appeared that there were not receptors in juvenile rabbits. And it was later in life those receptors started to appear. So different species, it may be different. And there's some animals like dogs, I don't think, get Clostridium difficile. Is that correct, Glenn?
They do, actually.
They do, actually. A horse is very susceptible. A hamster is very susceptible, of course. But it may be different across different species. And this, I guess, really, the pig neonate story is a little unique because I don't know if there's any other neonate mammals that we really see this problem. Is there?
We see it in calves and we see it in foals, of course. We've shown, in the case of pigs, that toxin A binds to enterocytes throughout the gut, plus other tissues in the body. Toxin B does not bind at all. And that's a different sort of precedent than in humans, where the work that has been done, which isn't very much and is not, in my opinion, conclusive, has shown that neither toxin A nor toxin B will bind to the gut to the gut surface of the newborn.
Okay, so there's a very different pattern of disease going from one species to another. What does this suggest to any of you, all of you, about how vaccines would be used in these different settings?
Well, one theory right now, and I think it may hold true across animals, at least in humans, is that in this first year of life, most of us were colonized with Clostridium difficile. And as you emerge from that first couple years of life, your antibody levels go up to toxins A and B, and this has been shown. So what this is the initial presentation probably of toxins at a time when we're not really vulnerable to them, hopefully, and are very vulnerable to them. And then we get an antibody response, we get immune memory, and that sticks with us most of life. And you don't, generally antibiotics given to someone in their 30s or 40s or third or fourth decade or second, third decade of life doesn't result in C. difficile, even if you controlled for exposure to the organism and things like that, you wouldn't see the same rates probably as you get with older people. And that's probably, and one thought is that that's immune senescence, that the immune system is losing that ability to ramp up antibodies. So the first year of life, exposure to C. difficile is probably the norm. And with that, we get an immune memory that then serves us well until we hit our 6th and 7th, 8th decades.
When we begin to lose all our memory.
Yeah.
Okay.
I don't know if you want to add anything to this.
Yeah, I mean, I agree with what Dr. McDonald said, and the preponderance of the evidence so far indicates that, where when you look at population-based studies that have been done, and again, they've been few and far between, but there has been some consistency where you see a ramp up of detectable antibodies in humans starting in early childhood, and then it plateaus off in the 20s and 30s, and you have immunity rates based on detectable antibodies in the 30 to 60% range of humans, just from looking for antibodies against toxins A and toxin B. And then it's been hypothesized that then as we get older, that starts to wane, and then as Dr. McDonald said, our immune system is unable to then ramp up an immune response when we're exposed later in life.
So the idea behind a vaccine then, except for those that would be used as therapies, would be maybe to boost that that sort of waning response in the middle-aged population generally, or in hospitalized individuals? I mean, when would you deploy such a vaccine?
Well, that's why you should come to my talk. But I mean, that's the challenge, really, is that we don't have an HAI vaccine, a healthcare-associated infection, a vaccine for a healthcare-associated infection so far, unless you consider hepatitis B vaccine one, and that's a debate. But this is going to be a question whether it's a Staph aureus vaccine, another very important pathogen, or Clostridium difficile is. I'd almost like, yesterday we heard about from the head of Novartis, reverse vaccinology. We're going to need to do some reverse epidemiology and look back and try to define cohorts at points in time where vaccinating them will make a lot of sense and will be cost effective. And the problem I see also is it's going to have to be done for each country because healthcare delivery is different. probably in different countries. I think for the U.S., this is something at CDC we're trying to step up to. And we think that the Emerging Infections Program and other tools like longitudinal electronic data and things like that, we hope to be able to get this better. Because you need to vaccinate people 8 to 12 weeks or even 16 weeks before they're at maximal risk. So maybe it would be an older population that goes in for elective procedures, or maybe it's an older population with some underlying disease that goes in for a procedure because they're going to get antibiotic exposures and go on.
And just to be fair to pigs for a minute, not that we have a mandate to be fair to pigs, what would be an appropriate time to vaccinate? At newborn pigs, or the mother, the sow that's carrying the pigs, or just as a kind of a hypothetical, but.
Well, to be effective, the vaccine would have to be delivered to the sow, probably in 2 doses, initially at least, maybe 5 weeks and 9 weeks prior to what we call farrowing, the birth of the pigs. And then, of course, neonatal pigs, along with many other domestic animals, are born without antibodies. So they pick up their passive antibodies by nursing the sow, and in the first 36 to 48 hours, what they're ingesting is called colostrum, and that's just loaded up with antibodies, which then pass from their guts into circulation, and they have their level of protection. So since the disease occurs in pigs from birth to 7 or 8 days of age, there really isn't any future in vaccinating them, but rather vaccinating the sow.
Okay.
There is actually an abstract here on a vaccine in a horse model, just as you described. It's a modified toxin vaccine, I think, looking at the enzymatic domain, and they're administered it to the mares and showed efficacy in preventing disease in the foals. So concepts.
So that's an established concept.
Well, it's an emerging concept, sure.
Okay. Let's see, we have a couple of questions in the room. Wait for the microphone.
Hi, Charlene Lena, WebMD. Can you go into the latest figures you're going to present on community-acquired disease and the C. diff, and also what are the risk factors as opposed to for hospital-acquired?
So it was a little difficult to understand. Can you repeat your first question?
Yes, I wanted to know the latest figures on community-acquired C. diff, and also if you could discuss the risk factors as opposed to the risk factors for hospital-acquired.
Okay. So that was actually one of the beginning of my talk. I'm going to be discussing actually some of the difficulties in me being able to prepare my presentation because we don't have good systematic surveillance in the community setting for C. difficile. We've been lacking in the healthcare setting for quite some time, and that's finally improving over the last decade. But for C. difficile in the community, again, we're still several steps behind from a surveillance standpoint from where we are in the healthcare setting. There's a whole range of estimates out there using a variety of methods to do the surveillance, but in general it appears looking at the entire population, there's an incidence of about 20 cases per 100,000 people per year. When you take all the numbers as a whole, with a wide range of incidents from as low as 5 cases per 100,000 to as many as 50 to 60 cases per 100,000. And again, because of this lack of surveillance, most of these are 1-year snapshots or maybe even a couple months snapshot of what's going on in a particular community, so we really don't have a good idea as far as what's been going on over time in the community as well as we have an idea in the hospital setting. Some studies have shown an increase in C. difficile in the community in the United Kingdom as well as in Canada, but other studies from those same areas, just looking at a snapshot over a period of a year or so, indicate that, well, maybe in some areas they already had higher rates. Again, it may be possible from the data source, the early years, they didn't do as good a job of capturing those C. difficile cases. So we don't know exactly what's going on without having a good surveillance system in place. As far as risk factors for community onset C. difficile, the main risk factors, actually, the highest period of risk are people just discharged from a hospital. And you see kind of the first couple of weeks after they're discharged, then a rapid decline in the number of cases to about 12 weeks after discharge, where you then get to kind of what appears to be kind of a baseline incidence of C. difficile risk in the community. Again, advancing age and antibiotics are also important risk factors, but they don't appear to be as common as what we see in the hospitalized population, where typically you could see 90% plus of patients in the hospital are exposed to antibiotics before C. difficile infection. Some studies in the community has seen as few as 46% of the people with an identifiable antibiotic exposure. Again, some of this discrepancy may be related to how they're capturing these data and what people recognize as antibiotics versus other medicines. And this reminds me of a case that Stuart Johnson presented during a session that we were both giving, a case that he saw when he was in Minneapolis. They had an elderly man come in with C. difficile infection, and they couldn't find any antibiotic exposures. And he said he received some sort of pain medicine a couple of days before he had symptoms, something his wife had left over. His wife brought in that pain medicine, it was amoxicillin. So I think there may, we don't, because of the lack of a good systematic surveillance system to capture these sort of data, it's not exactly clear. And again, when you look at people with C. difficile onset in the community compared to other people in the community who don't develop C. difficile, again, they're more likely to be exposed to antibiotics, or older and sicker than the rest of the population. So there's likely a spectrum of risk. And again, it's those older people on antibiotics, when you see C. difficile in younger people, they tend to have other underlying conditions such as lung disease, renal disease, or they're immunosuppressed for one reason or another.
We have a couple of people in the room who want to ask questions, but I have to follow up. Did the amoxicillin cure his pain?
I'll have to check. I don't know.
I'm sure. We have more serious questions in the room.
Probably worked if you had an earache or something. I want to follow up on the who's most susceptible to C. diff and whether a vaccine will work. It seems that passive immunity works, whether it's in pigs or neonates get maternal antibody. What you referenced in terms of the monoclonal seems to work from what you said. But does C. diff infection raise any protective immunity? And that sort of brings up the question of, are these people able to respond to a vaccine or toxic or not?
Yeah, C. difficile, natural C. difficile infection does raise antibodies in the majority of patients across the board, and that's been shown. In the minority that it does not raise antibodies, those people are more likely to have a recurrence. And the recurrence rate with C. difficile is quite high, 20% or so. So you're right, there's a subset that may not be good responders. With that said, there is, with this Sanofi vaccine, a case report of 3 chronic recurrent cases, which are generally antibody non-responders, that they were able to cure with the vaccine. So there's an N of 3 where it seems like it can happen. With that said, I mean, Sanofi is working right now with adjuvants also because of those kinds of issues.
And since antibiotics are a risk factor, is there any work looking into probiotics?
Yeah, probiotics is something people are very interested in, and you've touched on. In fact, there was an abstract here I saw yesterday from Toronto that they're working actually on how best to collect stool specimens and preserve them for stool transplants, because that has been, at least anecdotally, through case series, quite effective at curing people with chronic recurrences, who, by the way, when someone's had 3 or 4 recurrences, their likelihood of having another recurrence is over 50%. It's very, very high. And yet, case series of tens, dozens of cases suggest almost 100% cure rates in those cases, in those situations. So there's real an outcry among some parties to try to do a randomized controlled trial, which shouldn't be all that difficult because of the numbers won't be all that big. And I think there's talk about that in Canada, and so they're looking at that. In terms of single probiotics, which most people would rather, so I'm talking there about fecal transplants between a living, unrelated or related donor, often it's a spouse, and transplanting through a fecal enema or a endoscope procedure, or even through an NG tube down from above, as unpalatable that is. That has been shown, effective in terms of these anecdotes. Of course, people would rather just take a pill, would rather take a capsule with a single probiotic. The data on that is the IDSA guideline, at that point, we said it's equivocal. I think it still is probably equivocal. There's some studies that suggest it works. Other studies are negative. There's always a bias to only publish positive studies. So it needs to be better studied. The problem there, of course, is this is one probiotic, one organism for a community which is, very, very deep and rich and complex. So.
One microorganism.
One microorganism, yeah, one species.
And one organism being the host.
Well, yeah, but with a very rich and diverse microbial community living in the lower intestines normally. And some studies suggest over 1,000 species. I've heard actually higher numbers than that. And that's part of the focus of the Human Microbiome Project in trying to understand that. Half of which, by the way, have never been cultured in vitro, by the way, in terms of the unknown.
Okay, we have another question.
Yeah, and actually, due to time, we're going to make this the last question.
The last question.
Just one quick question on surveillance. Collection of just numbers, but is anybody going to collect data not just on prior antibiotic exposure, but also things like proton pump inhibitor exposure?
Yes. Yes, the Emerging Infections Program has sort of a deep dive into the community-associated cases with a 25-page data collection form and a sampling of that. So we'll get a better picture, especially the community-associated disease, at some of these other issues.
All right. Any final comments from the panel? No? Okay. Well, I've been talking with Clifford McDonald of the Centers for Disease Control and Prevention, Erik Dubberke of Washington University School of Medicine, and Glenn Songer of Iowa State University. This concludes another session of ASM Live at ICAC. We have another session in about 15 minutes. Thanks for joining us.